Doctor, we appreciate your time today. Our topic is menopausal medicine. What's new in menopausal medicine?
The interesting thing that's happened in the last 3 to 5 years is that the pendulum has begun to swing back on our opinion of the benefits of hormone therapy for menopausal women. Back in 2007, the International Menopause Society came out and said that women under 60 don't have to worry about the safety risk or the safety profile for hormone therapy. The risks are much less than the benefits that women have. Then in 2008, the American Association of Clinical Endocrinologists, these are the doctors who take care of endocrine problems such as thyroid, diabetes, and hormone issues, came out and said that young women getting hormones have no increased cardiovascular risk and may even have some benefit from hormone replacement therapy that she receives in her 40s, 50s, and maybe even into the early 60s. Then last year, the Society of Gynecologists and Obstetricians in Canada came out and said, we need new guidelines. We need to reverse the negative image that hormone replacement therapy got after the Women's Health Initiative back in 2002. And then this year, two things have come out. The North American Menopause Society, which is doctors who practice menopausal medicine in the United States and Canada, said that there's new evidence about estrogen and progestogens, and that each one is unique, each has its own benefit, and some even have different risks. The second thing that came out is that the Endocrine Society, these are endocrinologists in North America, a slightly different group, came out with a very authoritative scientific statement. And that scientific statement said there are numerous benefits for women beginning hormone therapy in the 50s, late 40s, and that these women probably need to look at the risk and benefits with their doctors, and it's probably going to be beneficial overall.
What are the benefits by age group?
Early on, you can probably begin to see some improvement in cardiovascular health. There are two studies that are coming out of Europe, coming out of the United States later on this year. The KEEPS, K-E-E-P-S, and the ELITE, E-L-I-T-E study. I'm looking forward to seeing what these two studies talk about coronary artery disease in young women. Now, the other benefits that we know from this scientific study is that hormone replacement therapy dramatically improves risks of diabetes. It makes a difference. One fewer woman per every 100 women is going to develop diabetes. Diabetes is the thing I'm seeing most here in East Texas. Women they're sedentary, they eat too many calories, need to change their diet, and those are going to be the consequences that are more likely to hurt them than just their concerns about breast cancer.
With respect to hormone replacement therapy, what are the real risks in absolute numbers?
The real risk in absolute numbers talk about somewhere between one extra case between 1 per 200 and 1 in 1,000 women. Now, that means that if there were 43 women who had breast cancer per 1,000, the extra risk might be 44. I don't know the real number of what that is, but that's what I'm talking about. In all these surveys, they talk about, and all these major studies, they give you relative. It's just relative. Well, going from 43 to 44 means that it dropped from 957 down to 956 don't have it. So the absolute risks are all in the range of 1 in 200 to 1 in 1,000. We know that women on hormones have fewer fractures and fewer deaths, and that's in the range of 1 in 200 to 1 in 100. We know fewer cases of diabetes. 1 out of 100 at least improve with one fewer case of diabetes at that rate. Some estrogens, like Premarin only, was even protective against breast cancer for women who did not have a uterus. As we look at the various compounds, the transdermals, the patches, the pills, and the different progestins that we use, they're each individual in their effect on the woman. And she needs to get with her care provider to evaluate what's right for her.
You mentioned it earlier, the Women's Health Initiative, WHI. What is it and how do we interpret it?
Back in the 90s, they wanted to evaluate what benefit there would be for hormones, and specifically Premarin, Prempro, and Premphase, specifically Premarin and Prempro, about improving coronary heart disease. Well, what we found out after that is that improvement in the 50s, neutral in the 60s, and probably bad in the 70s. And these were starting women out 5, 10, 15 years, 20 years later. So it wasn't about menopausal symptoms. It was a heart study, figure out what the heart drug was. In the women I want to address in our talks today, these are the symptomatic women between 45 and 60 who were miserable with quality of life, hot flashes, osteoporosis or low bone mass, osteopenia. Those are the things I'm concerned with. In fact, I'm more concerned about women who are scared of the fright that the health media puts out about bad things that can happen. There's a lot of good that can happen to women for hormone replacement therapy for women who are symptomatic. If you have symptoms, I would say evaluate your quality of life. What do the hormones provide as quality of life? And then take it, and don't worry about the uncommon consequences that arise.
What if a woman who was at one time taking hormone replacement therapy and out of fear of some fear or for whatever reason quit? What if she wants to resume?
I think that there are real benefits to starting back up symptomatic hormone therapy anywhere up to 6 to 10 years out. Now, the younger the woman, I'll let it go 10 years. The older the woman, maybe as short as 6 years out. So if she's still symptomatic, I'll be glad to consider that with her and go over the risks and benefits with her. I think almost any woman will benefit from topical urogenital estrogen therapy. By that, I'm trying to improve symptoms of overactive bladder and reduce the number of urinary tract infections that the woman will have in a year's time. Those are the real benefits that I see for women who are older than 60 or 65 or 70. The estrogen really helps their pelvic floors. They feel better, they don't hurt, fewer urinary symptoms, fewer urinary tract infections. It's a big quality of life issue in my practice.
At one time, you and I talked about natural hormones and bioidentical hormones, and we talked then, today is now. What's new about bioidenticals?
The bioidenticals that have come to the market in the last few years offer new opportunities and new options for women. The plain oral estradiol that you can get for $4 a month at any of our local or less at our local pharmacies are bioidentical. It's the same estradiol that's made in the ovary. The patches, the creams, the gels that women can apply are bioidentical, and there are brands of those that are FDA approved. The FDA approval is important so that you make sure you know what you have and each dose is standard. A bioidentical progestin is prometrium. For my patients, I'll let them use it 4 times a year just to prevent a cancer of the uterine lining from arising. One other thing that we've learned in the last 2 to 3 years is that I can administer small amounts of estrogen for urogenital issues, and I don't have to worry about cancer of the uterine lining, and that way the woman just applies something topically and gets the symptoms. I don't have to add anything else.
What other organs may benefit from the early use of menopausal hormone therapies?
Skin. Skin is a big benefit. And now, those of you women who have continued using your hormones all throughout the last decade, now look around and see your skin is young and healthy. Let's face it, a big aerobic activity for East Texas women is gardening. And healthy skin is necessary if you're going to be working in your gardens. Other things may be teeth. We know bone. And the exciting thing I'm thinking we're going to find in the next 2 to 3 years is early administration of estrogen in the perimenopausal time period is going to make a big difference on heart disease.
Very well. Doctor, thanks for your time.
Well, thank you. Appreciate it.